Welcome everyone. Today we are focusing on dental management of two highly relevant systemic conditions, which are chronic kidney disease and sexually transmitted diseases. So our goal today is to provide concise, practice-focused guide. We will cover how to recognize oral manifestations and adapt our treatment protocols, safely manage drug interactions, and navigate real-world clinical case scenarios at the end. So let's begin with the chronic kidney disease. So to understand the clinical impact of chronic kidney disease, we first have to look at the sheer scale of the disease. So nowadays, chronic kidney disease is one of the most burden diseases worldwide. So approximately 11% of the US adult population is affected by chronic kidney disease, and over 870,000 patients are currently managing end-stage renal disease. So the most critical takeaway here is that the early stages, which is from stage 1 through stage 3, are mostly asymptomatic. And the primary driver of this disease is diabetes mellitus, constituting 44%, followed by hypertension. So chronic kidney disease is classified into 5 stages based on the glomerular filtration rate, or what's called GFR. So for stages 1 through 3, our focus is on screening and managing comorbidities, for example, or such as hypertension or diabetes mellitus. The clinical paradigm shifts drastically at stage 4, where severe reduction in GFR means we must consult the patient's physician before invasive care and strictly avoid nephrotoxic drugs. By stage 5, the patient is in renal failure or on dialysis, and at this point, strict dialysis protocols apply due to high bleeding and infection risks. So, what are we looking for when these patients sit in our dental chair? There are some oral manifestations for chronic kidney diseases, either affecting soft tissues or hard tissues. In soft tissues, we may notice signs and symptoms of anemia, for example, mucosal pallor. Also, uremic stomatitis, one of the most common white lesions associated with chronic kidney disease due to elevation of urea and ammonia. Patients often report metallic taste or an ammonia-like breath odor, رائحة تشبه رائحة الأمونيا. And on hard tissues, there are renal osteodystrophy. Classic signs include ground glass appearance, loss of lamina dura, central giant lesions known as brown tumors. This is due to the secondary hyperparathyroidism because of renal failure. And in pediatric patients, we can notice that there is delayed eruption and enamel hypoplasia. So when it comes to treatment, timing is very, very important. Everything. The golden rule is always schedule elective dental care on the day after hemodialysis. Do not schedule the dental treatment on the dialysis day. So never treat on the day of the dialysis because the patient is fatigued. أيضا بيكون there is an effect of heparin. So that's why we schedule on the next day. Plus, never place a blood pressure cuff or IV on the arm that has an AV fistula or shunt. So keep in mind also regarding the we must aggressively monitor blood pressure and avoid nephrotoxic NSAIDs or non-steroidal anti-inflammatory drugs. So let's talk about hemostasis, which is very important in association with chronic kidney disease. A vital clinical peer to remember. Platelet dysfunction في حالات اليوريميا is qualitative, not just quantitative. يعني كمية البليتلتس بتقل وأيضا الفانكشن تبعها. So this means a normal platelet count does not guarantee normal clotting. So therefore before surgery we should obtain a platelet count, hematocrit, وأيضا coagulation status. So always use meticulous surgical techniques, primary closure, local hemostatic agents. لازم تكون عندنا local hemostatic agents in case of bleeding, such as topical thrombin, gelatin sponge, collagen, oxidized cellulose, and of course sutures. So prescribing medications for chronic kidney disease patients requires extreme caution. We need to be cautious, حذرين لما بنوصف أدوية للمريض المصاب بالchronic kidney disease. So we need to avoid non-steroidal anti-inflammatory drugs entirely, as they inhibit renal prostaglandins. So for pain, the safest alternative or option is acetaminophen. If prescribing antibiotics such as amoxicillin or cephalexin, we must adjust the dosing interval. So there should be dosage adjustment أو إعادة ضبط للجرعة. Crucial rule is to administer medications after patient's dialysis session. يفضل إذا راح نوصف دواء نوصفه في اليوم التالي من الغسيل الكلى, so the drug is not immediately filtered out of their blood. بالتالي أضمن أنه هو ما صار filtration للدواء. So common misconception is that AV shunts require antibiotic prophylaxis. حسب التوصيات من ال AHA guidelines, routine prophylaxis is not recommended solely for intravascular access. يعني بس مجرد انه هو مركب ال AV shunts, so doesn't require انه هو ياخذ antibiotic for active infection. However, remember that dialysis patients carry higher risk for blood-borne pathogens بسبب نقل الدم, فبالتالي هو عرضة لإنفكشن زي الهيباتيتس بي أو سي أو ال HIV. وبالتالي نحتاج إن احنا to follow good standard protocols for infection. Okay, now let's end this topic by this case. We have 85 years old end-stage renal failure disease patient on hemodialysis who presents for an extraction on Friday morning, just 3 hours post-dialysis, فقط 3 ساعات بعد الغسيل. What's your next step? Okay, so pause the video and try to answer the question. Yes, exactly. The answer is C. We must defer the extraction to the day after his next dialysis, as per the protocol. Thanks for your listening, and see you in the next topic, inshallah.